Can you hear me? Hello, hello. Okay. Can you hear me? Can you hear me now?
Yes, yes.
Aha.
Hello.
Hello. Okay. Can you hear me?
We can hear you, doctor.
You can? Okay. Do you like me to start?
Yes, please.
So I can share my screen?
Yes.
Okay.
Good morning, Professor Nicholas Jeffrey. I want to make sure that you hear me right, okay?
I can hear you now, yeah.
It's perfect. It's perfect now. Excuse me, it's just I'm not familiar with the Zoom program. So I take some time to make accommodation and to make adaptation to our system here. I would like to thank you for your acceptance to give us this interesting lecture. First of all, I would like to welcome and introduce Professor Nicholas Jeffrey for our graduates and postgraduates and practitioners, veterinary practitioners. Professor Nicholas Jeffrey is a professor of neurology in Texas A&M Veterinary College. He is also a chief editor of Journal of Small Animal Surgery. I would like to welcome him for our lecture today, and I would like to thank him for this interesting event that he accepted to share with us his experience. And I'm sure that we will, at the end of the lecture, we will be very satisfied from the content that he prepared for us for interesting lecture titled How to Differentiate Between Neurological Affections and Orthopedic Affections. Thank you, Professor Nicholas Jeffrey, and I hope that I have a good English, little. Okay, so thank you, and we could begin now.
Okay. Well, thank you for inviting me, and I hope that what I've got to show you is useful. I I've used this type of preparation before. I'm just wondering, I just got to know which screen I've got to share. Let's just see. Is that sharing?
Yes, Professor Nicholas, you will find a button at the distal part of the screen named Share Screen.
Yeah, the thing is that it's covered up. I might have to. When it's sharing the. I've got to make sure it shares the right screen. So, okay.
Yes, it's perfect now. I can see the presentation on my screen now.
Can you?
Yes.
That's interesting because I can't. So you can see the presentation.
Yes, I can see the presentation now.
Okay, that's quite interesting because I can't see it. I can see the slides.
You cannot see?
I can't see it as a presentation, but I think it's probably okay, actually. I think it's probably okay. I'll see how it goes. It's just I've got a lot of videos to show, and so it's just whether the videos are going to work.
Mm-hmm.
Okay.
Okay.
So the question here is about whether something's orthopedic or neurological, and to some extent, the more I think about this question, the more I think that maybe it's almost a non-question, and the reason why I think it's almost a non-question should become apparent as I present these videos. So the main question here, can you see the next slide?
Yes, Professor, I can see.
That's fine. So
Yes.
the main reason that we're interested in whether it's orthopedic or neurological is to do with focusing on lame animals. And so I've got a whole load of videos to show you that show some examples of different types of neurological or orthopedic disease, and then how we can go about differentiating those. So I'm going to try and run this video, and I'm not sure if this was going to run.
Yes, I can see the video now. I can see the video running. Yes.
Okay. So one of the things about this is that some of these cases have very obvious clues that they're neurological or orthopedic. This one's a neurologic case that's very clear because it's got the paresis, so it's got the lack of voluntary movement. So it is able to place some weight on the leg. It's able to pronate the leg a little bit. It's particularly lame on the left front leg. One of the other clues that it's likely to be neurological is the fact that the back leg is affected as well on the same side. And it would be rather unusual for that to be an orthopedic disease that was causing a hemiparesis that was affecting two legs on the same side. Mm-hmm. Has the title of this slide, has the cause come up? Does it is my title come up to tell you what this is on the presentation?
Excuse me, Professor, can you repeat the question, please?
I have a thing at the bottom that tells what this lesion was. Has that come up on your slide?
Yes. Yes, it is written here that it is vascular myelopathy, fragmented lower fiber cartilaginous embolism.
Yeah, unfortunately, it was meant to come up as an animated part of the presentation. So it's a bit disappointing that it's coming up before, so that it's telling you what these things are. I rather wanted that not to happen, but it looks as though I may not be able to avoid that. Okay, right. So the next one is another dog that's got a very obvious sign that's suggesting neurologic disease. As you can see, this dog is unwilling to bear weight on this leg, but it will bear weight so that it's able to put more or less full weight on this back leg when it wants to. but it just doesn't really want to do it. And so it's showing a very typical sign for a nerve root signalment, that it's got pain that you could think is originating from a nerve here, rather than it being a joint disease. So you could imagine that some of this posture looks a little bit like a dog with a cruciate rupture, perhaps.
Yes, yes, I want to ask about this. Yes, yes.
But the way that it's holding the leg at rest like that is maybe a little bit suggestive of a lumbosacral nerve compression. This dog does have a lumbosacral nerve compression, actually. We diagnosed that later. And I'm afraid that the titles come up to tell you that, which is a bit disappointing.
Yes, not all.
So
no, it's very good.
some of these, some animals are very difficult to tell apart by just looking at them. This is a dog, and again, the titles come up to tell you what this is, but this is a dog with aortic thrombosis. And I think that this one's a difficult case to better pick out by just examining it on a video. And one of the reasons is that when the dog is walking, it's able to take fairly normal steps. It's got shortened strides. But the main thing that this dog's showing is that it's got like a very severe exercise intolerance, or a lack of willingness to exercise.
Severe, yes.
And
Severe
so
muscular intolerance, yes.
Sorry, say that again.
Severe exercise intolerance, okay?
Yeah, it has a very severe exercise intolerance. And so that tends to lead you down the line of thinking that this could be a neuromuscular disease. And I suppose in some ways it is. This dog has an aortic thrombosis, so that the blood supply to the back leg is impaired. And so it leads to neuromuscular perfusion disorders that will lead to a very profound exercise intolerance. When you look at this, I suppose it could possibly be an orthopedic disease. It's potentially showing signs that could be associated with severe hip problems, I guess. Perhaps it could have a low back problem. I think a more general consideration looking at this is that it could have a more generalized neuromuscular disorder, perhaps myositis, perhaps a neuropathy. But the clear thing is, when you examine these dogs, you can often feel that they have no pulse in the femoral artery, and so that's the obvious clue. And you can diagnose them more precisely by using ultrasound, or by using blood pressure measurements in the back legs, so that you can measure the blood pressure in the back leg and compare it to the blood pressure in the front leg, and that will give you the clue. And then you can diagnose them by ultrasound, or MRI. Actually, I mean, you can see the blood clot in the aorta on an MRI.
But it is, I think, it is little confusing. And what it is the last case, little confusing, right?
Yeah, that's right. It's not that straightforward. The thing is, on physical exam, you can usually diagnose. You can be pretty sure that they've got this on physical exam. In most cases, you just do a physical exam, and you can feel that they don't have a femoral pulse. And so there's a pretty strong clue just from physical exam. But it's just to reiterate the importance of carrying out the physical exam as part of a general thing. When you're looking at an animal that's got orthopedic or neurologic disease, the entire exam is an important component. That you shouldn't just focus in on the affected leg and the affected joints and things. So again, this one there is being spoilt a little bit by having the title come up, but this is a dog that presented to us in neurology. This is when I was working in Iowa State. So it presented to us in neurology because it's got the obvious problem here of hyperextending at the hock, and it's hyperextending at both hocks. And so that can be a very classic presentation for problems with the sciatic nerve, particularly with the distal part of the sciatic nerve, that it's showing a problem there. But I think when you look at the way that this dog's walking, this dog doesn't look as though it's ataxic. It's placing its legs very clearly. It doesn't particularly seem painful either, actually, although neither of the conditions that you might think about would necessarily be painful. So the main differential diagnosis is that it's got a calcaneum tendon rupture. And I think that one of the things, if you look very closely at this video, does tell you that it probably is orthopedic rather than being neurological, is if you look at the back leg paws, they're very scrunched up into balls. And so that gives you a clue that it's an orthopedic disorder. If it was a neurologic disorder, you'd expect the paws to be splayed out, because if it's lost the neurologic input into the gastrocnemius, it would likely also lose the input into the paws. And so then its paws would splay out. But this dog is curling up his paws quite a lot, which tends to tell you that the flexor tendons are intact and working, but the gastrocnemius isn't working okay. And so he's hyperextending at the hocks, but he's hyperflexing at the toes. And so it tends to tell you that that's more likely to be an orthopedic disorder. And this is a dog with a bilateral calcaneum tendon rupture.
Can I ask a question, Professor Nicholas, for this last slide?
Yeah, sure.
Thank you. This gait is named plantigrade gait, or plantigrade stance, right? It is a little diagnostic for tendon affections or not?
Yeah, well, it's not completely plantigrade, but it's partially plantigrade. And I think the differential diagnosis here is between a sciatic nerve disorder, including lesions up in the spinal cord, L7 spinal cord, and orthopedic disorders. I think that's the differential diagnosis here, really. Yeah, yeah. It could be maybe a more general neurologic condition. Some dogs with general neuropathies will present a little bit like this because the back legs are often more affected than the front legs. So you look at this, and I think there are some clues that make it look as though it's orthopedic, but it could be orthopedic or neurological when you first look at it.
Can I say something else, Professor Nicholas? I usually tell our students and our postgraduates that orthopedic affection have a abnormal regular gait, but neurological affections have abnormal irregular gait. I cannot expect where the next step of the dog will be. I cannot expect. This is a neurological affection. But if it is orthopedic, I can expect even he was lamed. I can expect the next step or his pause where it will be the next step, right?
Yeah, that's a very good description of ataxia, and I would agree with your description of ataxia. The problem that you have with that is that if you've got peripheral nerve disease, I would say that most animals with peripheral nerve disease, and this includes lumbosacral disease, most of those dogs I don't think are ataxic. They don't have sufficient disorder of the proprioceptive positioning to become ataxic, I think. And so we would generally not think of animals with peripheral nerve disease as being ataxic.
Thank you so much, Professor. Thank you so much.
So the next condition here is one, again, it's got the title on it, but this is a dog with a bilateral cruciate rupture, and this is probably the most common disease that we get presented as neurologists. This is probably the most common orthopedic disease that we see, dogs that present with cranial cruciate rupture, because it's just so common. And that my reading of lame dogs, hind leg lame dogs, I would say that they're all cruciate ruptures until you've ruled it out, because it's so common. And that, you know, almost every time, and I think most orthopedic surgeons would agree with that it's just so common for dogs to be lame on their back leg because of a cruciate rupture, that until you've ruled that out, that should be your -- diagnosis.
Yes,
when you see them when they're bilateral, they're a bit more confusing because they've got this short stepping gait, and weight shifting onto the front leg. And it makes it look a little bit as though it could be because they've got a painful back end. And I think that, you know, I'm going to go on and tell you, you know, how I think you should approach these cases next, but I can see why people might consider that that could be a neurologic disorder. As you say, this dog is not showing ataxia though, but it could have a low lumbar disease perhaps that might be causing it some pain, and so it's shifting its weight.
It means, in another words, Professor Nicholas, that bilateral affections like cruciate ligament ruptures or canine hip dysplasia produce some kind of stiffness of the hind limb that can be misdiagnosed with a neurological affection, right? What I said or not?
Yes, I think you're right. You're talking about the weight shift as well onto the front legs, aren't
Yes.
you? Yeah. So I think they'll do that with a lot of things, anything that causes pain or sometimes weakness. I think they'll shift their weight onto the front legs. And so then it changes the position of the back legs. So sometimes they look a bit stiffer. Yeah, I agree.
Thank you so much.
Oddly enough, I think animals with weakness in the back legs often will look stiff. I've got some examples of that in some other videos. So this one is a bit of a weird one, but it was presented to us in neurology, which is why I'm showing it to you. So this one is showing a palmigrade stance on the front legs. It's very, very palmigrade. I think on this video it can be a little bit difficult to see, but this dog is very, very palmigrade. Like it's got very intense hyperextension in the front legs and the carpus.
Yes,
palmigrade. Palmigrade, yeah. I think it's walking slightly plantigrade in the back legs as well, maybe. It's a little bit difficult to be sure because, again, there may be some weight shifting. This was a dog that was presented as possibly being neurological because you could imagine that it could be if it's got if it's got a nerve disorder affecting the innervation to the carpal extensors, then it could present in this way. This dog actually had an immune-mediated polyarthropathy that had been going on for a very long time, and it caused weakness in the joints such that it got so lax that it had produced this palmigrade and plantigrade stance. So being a neurologist, the way that we would approach these cases is to do a neuro exam, because if an animal has got neuro disease, then we should be able to localize it to a disorder. We should be able to detect a deficit in the neuro exam, and we should be able to put it into some compartment of the nervous system where the disease might be. And so we always teach everybody that we put our neuro diseases into categories in the central nervous system of brain, C1, C5, C2, C6, T2, T3 to L3, and L4 to S3, because of the constituents of the upper and lower motor neuron systems. And then we'll also subdivide to look at the peripheral nerve components as well. So we would do our neuro exam on any of these cases to try to see if we can put them into these components. So the first thing is to do your reflex tests. And so we're looking at the function of the reflex arc. This is a myotatic reflex where you tap a tendon and that stretches the muscle, and then you get a reflex contraction of the muscle. The only one that's really reliable is the patellar reflex, which we're showing here. And then the other reflexes that you can look at would be the flexor reflexes, where you're pinching the toe and assessing the ability to of the animal's strength to pull back sufficiently. And I think one of the things that people often miss when they're doing this is that they should be looking to see flexion at all the joints. So in the front leg, you're looking to see it flex at the carpus, the elbow, and the shoulder. And in the back leg, you're looking to see it flex at the hock and the stifle and the hip. The reason why that's important is that, especially in the back leg, it's very common to see animals that have a partial deficit. So that you pinch the toe, and yes, they do flex, and they flex at the hip and they flex at the stifle, but they often don't flex very well at the hock. And so common diseases at the base of the spine are associated with weakness in the hock, but not necessarily weakness in the stifle or the hip. And so it's very important to evaluate all those different components. The reflex arc does consist of both sensory and motor components. So it's important to bear in mind that you could have a loss in the sensory component, or you could have a loss of function within the spinal cord itself. That can be where the lesion's coming from. Even though it appears to be a peripheral nerve disease, you can't detect the difference between a lesion that's affecting the peripheral nerve and one that's affecting the CNS, because you're just affecting the reflex arc. And so the lesion can be anywhere in that arc.
Yes.
So
Yes.
finding a deficit in, say, the flexor reflex in the back leg, if you detect this weakness in the hock, the lesion could be in the peripheral nerve, anywhere between here and the spinal cord, in the sensory or the motor component, or it could actually be in the spinal cord itself. And so that can include up to L5 vertebra, where L7 spinal cord segment is. It's a lot further up than you think. So there's a lot of the nervous system that you need to be able to check to make sure that it couldn't be in, to rule out a lesion.
Yes.
So there are two low motor neuron centers in the spinal cord. So there's the L4 to S3 region, and really most times you're thinking about L7, S1 as being lesions that might cause lameness. Occasionally you do see them further forward, but it's usually L7, S1. And then the C6 to T2 region in the forelegs. We were talking before about ataxia, and so sorry, it's going to come up in a minute. So for the C6 to T2 lesion, you're going to have depressed reflexes in the forelimbs. If it's affecting the spinal cord, you're also going to get the depressed postural reactions, probably in the foreleg, but definitely in the hind leg. So a lesion that's affecting the whole of the spinal cord at this level, you would expect to be able to detect paresis or ataxia in the hind legs. And so this is one of those cases where you're right, where you're saying that if you've got a neuro lesion, that yes, it will cause ataxia. And I would agree with that if you've got a lesion at this level. The reflexes in the back legs are going to be intact if you've got a lesion at that in C6 to T2, because that reflex arc is unaffected. They may be exaggerated, they may not be exaggerated. It doesn't matter. The important thing is that they're intact, and it doesn't matter whether they're exaggerated or not.
Yes. Can I ask a question, Professor?
Yeah.
Thank you. It means that if we have a neural lesion between C6 and T2 spinal segments, it will produce hyperreflexia of the forelimb and hyperreflexia of the hind limb. And the hyperreflexia of the hind limb will be accompanied with paresis or paralysis or abnormal postural reactions, right?
Yes. The only thing I would say is that I wouldn't rely on having hyperreflexia. It's not a helpful distinction. It's better to just think about whether the reflex is intact or not.
Mm-hmm.
Whether it's exaggerated or not makes no difference to your interpretation. And the reason for stressing that is that occasionally you can get what's called pseudo hyperreflexia, and it can lead you to make an erroneous diagnosis. So it's better to just think whether the reflex is intact or not.
Mm-hmm. Thank you so much.
But apart from that, yeah, I would agree, yeah.
Thank you.
So for an L4 to S3 lesion, you're going to have abnormal reflexes in the hind legs, but it's important to stress here that these can be partial reflex loss. Like I said before, you might just lose the flexor reflex at the hock, but not lose the other ones. You're also thinking about lesions that might affect the continence, that might affect anal tone. And so it's important to assess them as well. Just occasionally you come across lesions that don't really affect the back legs all that much, but they very profoundly affect the anal tone or the ability of the bladder to retain urine. So it's important to compress the bladder, to check the anal tone as well, because that can give you a very strong clue that there's a lower motor neuron lesion there. I've put down here that the postural reactions can be affected. I'm not altogether sure that they can be, but in very advanced lesions, it's probably true that they can be. Of course, the forelegs and the head are going to be normal in an animal that's just got a localized lesion to L4 to S3. But I would again stress that a lot of generalized neuropathies often seem to much more profoundly affect the L4 to S3 region when you look at them clinically. And so you should evaluate the front legs very, very closely to find out whether it could be a more generalized lesion, because sometimes they're almost subclinical, the lesions in the forelegs.
Okay.
I don't know what access you've got to electrodiagnostics there. Do you have electrodiagnostic like EMG and things available to you?
Not, I don't think so.
No, okay.
No, unfortunately.
No, the thing is that the equipment is not particularly expensive actually, and it can be quite useful because here, if we've got any doubt at all about whether we've got a low motor neuron lesion, we will use the EMG to test, because it will tell us absolutely for sure if there is a low motor neuron lesion there, just by putting a needle into the muscle and listening to the sound that you get. It will tell you absolutely for certain, and that can be very useful to just make sure that your diagnostic effort goes one way or another. I won't go on about it too much more, but I would, it's worth thinking about getting it, because you can pick these up pretty cheaply nowadays, second-hand ones even.
Okay.
So the other part of the neuro exam that we were talking about, and you've mentioned, is about the postural reactions. And so I want to stress here about using tests apart from just doing the toe knuckling response, because everybody does the toe knuckling response.
Yes.
They don't necessarily do these other tests, and these other tests can often tell you a lot of information. So this is a dog doing a hemi stand, and then you can do more of that by just simply pushing the dog away from you to get it to hemi walk. So the dog has to walk sideways and it has to coordinate its legs to be able to maintain normal posture. This one is the extensor postural thrust, or the sort of backwards wheelbarrowing. So you lower the dog onto the table and watch it move its back legs to maintain normal posture. And each of these things, you're just looking to see the coordination to make sure that the dog can bear weight on put his leg down in the place where he needs to better do it to bear weight correctly. This is the hopping test, which again, you're looking to see quite a lot of information from doing this. You're looking to see, does it initiate hopping at an appropriate time, or does it delay it until it's almost falling over? When it lifts its feet, does it lift it appropriately? Does it lift it too high? Does it lift it not high enough? And when it puts its foot down again, does it put its foot down in a place that's appropriate to bear weight? Or is it putting it down in a place that's inappropriate? Is it inappropriately too far away from the body, or inappropriately not far enough, so that it's in an unstable position? You can pick up a lot of information from doing this. Very, very simple test. And you can do it in big dogs. It's easy to do it on a small dog, but you can do it on big dogs as well, just by picking up one foot. You don't have to pick up all the other feet. One of the other postural reactions that's often neglected, people do the toe knuckling test, and actually that's not a posture. It's not a test of proprioception. Actually, it's a test of tactile placing, really.
Tactile placing.
This test here, where you get the dog to bear weight on a foot, and then you pull the bit of paper or card away from the dog's body while it's bearing weight on it. So you sometimes need to just push the body a little bit so it's bearing weight. is a very good test of proprioception. This one does truly test proprioception, so that the dog, and it's a very sensitive test, so that the dog will immediately, it detects its feet moving away. A normal dog will correct this immediately. And so it's a very sensitive test of proprioceptive disorders.
Mm-hmm. It's very interesting. It is neglected. Was this test is neglected on a piece of paper? Which,
yeah.
Yes, it is.
It's
yes,
neglected by people here as well. Yeah.
Yes.
A lot of people here don't do it either.
Mm-hmm.
Yeah.
Tactile placing, right?
This one is, I don't know what, this one's called a sort of paper slide test. So, yeah. I don't know.
It identifies tactile placing, right? Tactile placing.
Tactile placing, I would use as the term for when you're bringing an animal, like especially a small dog or a cat, up to a table, and it's touching the feet, you know, on the table, and then it's lifting them onto the table.
Yes,
I would tend to use that term for that, or maybe even for the toe knuckling response is a tactile thing, that it's responsive to the tactile stimulation.
Mm-hmm. Yes, yes. Thank you, Professor.
So the question here is about what do the postural reactions tell you? And theoretically, they're testing all the ability for sensory information to come from the foot, go all the way up the spinal cord, all the way to the brain, and for the information from the brain to come down in the motor pathways all the way down the spinal cord and down the effector pathways to move the leg. So theoretically, they're testing the whole of the nervous system from the point of testing to the head and back again. So they're testing a lot of the nervous system, which is why they're used for the screening for nervous system disease. I think the exception that I'd make is that I think for peripheral nerve disease, I'm not sure that it's quite sensitive enough.
Mm-hmm. Okay.
So the postural reactions, if you've got C1 to C5 lesions, you're going to have your abnormal postural reactions in both the front legs and the back legs, and your reflex is going to be intact and the head's going to be normal. So that's a good example of where your postural reactions and your ataxia are going to come in, but your reflex is going to be okay.
Yes, it is called upper motor neuron deficit, right?
Yeah, that's correct.
Yes.
And here's an example of a dog doing it. So this is a Great Dane that's moderately ataxic, I would say. It's swaying its back end a little bit. It's placing its feet inappropriately wide. The back legs are placed inappropriately wide, I think. Mm-hmm. And the front legs, it's doing an interesting thing where it's just very slightly hypermetric, I think. So this is often referred to as floating, that they float the front legs because they're reaching out just a little bit too far before they put the foot down. And so this dog is showing characteristic signs of postural deficit. Well, this is not the test, but it's showing characteristic signs of ataxia in all four legs. So when we see this as a neurologist, we're thinking that it's likely to be neurological when you see that collection of signs. And sometimes you just have to think, well, perhaps it's not even a spinal cord disease, that it could actually be a brainstem disease. And that's the big question there. If you localize to the C1 to C5 area, the question then is, how do we know that it's not in the brain? Because perhaps it's got a brain disease. And the most likely is going to be something in the brainstem. And if it's something in the brainstem, you're probably going to detect a lesion in one of the cranial nerves. And if you are going to detect something in a cranial nerve, the most likely cranial nerve you're going to detect a deficit in is going to be the vestibular nucleus or the vestibular system, just because it's a very big area of the nervous system that's involved in vestibular function.
Which is very common too.
It's very common, yeah. And so one of the things you might do is to do this where you're pointing the dog's nose at the ceiling and looking down to check that there's no strabismus. And also by putting the dog's head in that position, you sometimes can induce nystagmus. A test that I often do, that I haven't illustrated here, that we very commonly do to look for subtle vestibular deficits, is to put the dog on its back and to then extend the neck so that the nose is parallel with the floor, and then look at it while the dog is on his back in that position. And there's a lot of dogs that you can't detect spontaneous nystagmus, but when you do that, you can detect spontaneous nystagmus. So a lot of dogs that show that ataxia that I showed you before, we have the dogs come in that are like that, and we're thinking, is it spinal cord or is it brain? And we do the test where we put them on their back, and we can detect that they do, yes, have a brainstem disease because they show nystagmus. And it's a very useful test, because the way that we would go about our next diagnostic steps is completely changed by finding that nystagmus. So I would recommend that to you as something that's worth testing.
Can we say, Professor Nicholas, can we say that when an animal comes with ataxia of the forelimbs and nystagmus, spontaneous nystagmus, can we say that it's maybe little characteristic for vestibular syndrome or vestibular disease, or not?
Sorry, I didn't hear everything you said.
Can we say that if we find an animal with this line of symptoms, first ataxia of the forelimb and hind limbs, accompanied by spontaneous nystagmus, like the previous slide, can we say that it may be characteristic or diagnostic little for vestibular syndrome or not?
Yes, if the dog, I think if a dog has nystagmus and it's ataxic, that's telling you that it's got vestibular disease. It's not telling you where the vestibular disease is, although I think that there's quite a strong inference that that would be central vestibular, because it's relatively subtle, and most peripheral vestibular disease is very gross, like it's often very, very profound. And so something where you've got a little bit of a ataxic gait, then you've got nystagmus as well. I think you put those two things together, the dog must have vestibular disease. One of the questions about it, of course, is does it have vestibular disease and spinal disease? Because it could have two lesions. And there's a principle in neurologic diagnosis that you should try and explain everything with one lesion. It doesn't mean that the animal only does have one lesion, but if it's possible to explain it with one lesion, that's where the lesion is. And so if you had that Great Dane and it was ataxic in that way, and it's got nystagmus, then I think you say, yeah, we should be looking at the central vestibular area. We should be looking at the brainstem as the cause for that disease, because that would explain everything that you're seeing.
Okay.
Just for completeness, I've put the next slide up is about T3L3 lesions. And so here you're going to have your postural reaction deficits in the back legs, intact reflexes in the hind legs, forelimbs and the hair are going to be normal, of course. So this would be upper motor neuron to the back legs and normal front legs. So I just put this in for completeness because I've been running down all my neuro exam. So just wanted to have it all in there. So we've been talking a lot about CNS stuff, but I'm afraid this thing's come up again. This is a classic, is it ortho or neuro case? Because we see quite a lot of these through neuro. And the typical history for these is they're lame, an older dog that's been lame for about 3 months. It's been getting progressively worse. It first turns up, it presents to the primary care vet, and they say, oh yeah, it's lame, it's probably a shoulder, because they can't find lesions anywhere else. It's a Labrador, and they commonly get shoulder disease because of having OCD when they're younger. And so they commonly present with shoulder degenerative joint disease. They're put on non-steroidal drugs. They don't really get better. and then they progress and they end up coming into either neuro or orthopedics for further workup. And so when we see these dogs, the classic thing from our point of view that makes it look a little bit like it could be a neuro case is partly the history, that history of the lameness just getting worse despite treatment for like 3 months with normal x-rays pretty much tells you that it's likely to be a brachial plexus tumor.
It is very interesting. Yes.
The other thing that it could be, I guess, if you didn't have the x-rays, would be osteosarcoma probably in the humerus would be most likely, because it's least obvious. That the other ones usually have a big swelling. So it could present in that way. The other thing that we can tell on physical exam, usually, they often have much more profound muscle wasting than you'd expect. So especially around the shoulder joint. So they often have very, very profound wasting of the infraspinatus and supraspinatus muscle. And so they start to show us that they're probably going to be neuro. The other thing is on physical exam is that they will usually show deficits. So that when you do your neuro exam, they usually have deficits in withdrawal reflex, that they will show deficits. The other thing to bring up about brachial plexus tumor dogs is if you do the panniculus exam, some of these dogs do have deficient panniculus reflex because this C8 nerve root is affected, and so the panniculus on the same side as the lesion is deficient. Very advanced cases will also show deficits in the back legs. So the ipsilateral back leg will be affected. If the tumor is large enough to expand into the spinal canal and compress the spinal cord, they will show postural erection deficits in the back leg, and sometimes even you can see it when they're walking. This dog I don't think does show it. I think it's just showing lameness.
It's a very interesting case. The last slide is very interesting.
So yeah, we see them a lot through neuro. We see a lot of nerve sheath tumors that we operate, but it's quite a common diagnosis for older, maybe large breed dogs. It's my impression, but maybe not. But and the history is the thing that when we hear it, it's got a very typical history, that they haven't responded to treatment and they've just got worse. So if you've got a lesion in the peripheral nerves, then you get depressed reflexes. It may affect many peripheral nerves, or it may just affect one, because it depends on the type of the lesion. I've put down here that it can cause abnormal postural reactions. It can do if it's very severe. And maybe I'll show you, I think I might be able to show you a video in a minute of stuff where they have got depressed postural reactions, but they usually have to be pretty severe. The mentation is normal. Now you may think that's crazy. Why would you even worry about that? But the reason is because of having animals that have got very profound weakness, that can't get up, that you might think that they've got a head lesion, that they've got brain trauma, because they're so profoundly depressed. And so one of the important things is that you sometimes see animals with generalized peripheral neuropathy that just look as though they're completely non-responsive. But actually, when you look at their mentation, they're okay. And some of them actually do wag their tail and stuff like that, because they're still, of all the motor component that's left, it's usually their tail that seems to be the one that persists through. One of the important things is to remember about generalized disease. And it's very disappointing that the title of the slide is coming up on this.
This is still very interesting. It is still very interesting, yes.
The classic presentation of hyperkalemia in a cat. So it's got a generalized weakness. It's got a resistance to, an inability or a not wanting to walk very far. It wants to keep resting. It's got very profound exercise intolerance. But the thing that's very, very characteristic about hyperkalemia or any sort of neuromuscular weakness in a cat is this ventriflexion of the neck. The ventriflexion is because of the neck muscle weakness. It's not a sign that you see in dogs because they have a nuchal ligament, and so they're able to maintain their head posture much better than cats. But cats don't have a nuchal ligament, so when they lose their muscle tone, then they develop this very profound neck flexion that tells you that it's got a neuromuscular disease. This case is hyperkalemia, but it could be any other sort of generalized neuromuscular disease. This is another classic presentation in a cat with diabetes. So this cat is showing a plantigrade stance. It will show it in a minute. Again, this cat has got a generalized neuromuscular disease, but it shows it particularly in the back leg. It's just very common for dogs and cats to show weakness, and neuromuscular weakness particularly seems to show up in the back legs. And in diabetes mellitus, the plantigrade stance is a very characteristic sort of almost pathognomonic feature of diabetes. This is a dog with muscular dystrophy, but it's showing a lot of characteristic signs of an animal with weakness in the back legs. So it looks stiff. I think if you were describing this to somebody else, you'd say this dog has got a stiff back leg gait. And I think, interestingly enough, animals that have got stiffness, that have got neuromuscular weakness, often do show what might be described as stiffness. So it's got short hind limb gait, doesn't want to walk very far, the steps are very short, the weight is tipped forward onto the front legs, and he's just unwilling to walk. So it could be a lot of different diseases. This is actually a neuromuscular dystrophy case from a colony in Paris, actually, where they have a colony of dogs with muscular dystrophy. This is a dog with a generalized neuropathy that's a bit more subtle, but I think he's showing an interesting part of the gait. So this is a Leonberger. So this is a Leonberger neuropathy. They have an inherited neuropathy. But the gait pattern that he's showing here is that he's not flexing the hock appropriately when he's walking. You can see him flexing the stifle, and he's probably flexing the stifle too much, and he's not flexing the hock enough. So he's compensating for the distal weakness by flexing the stifle excessively. And I think you see that quite commonly on animals that have got chronic mild neuropathies. I think that is quite a common presentation. This one's obviously a neurologic condition, but I'm just showing it to you because it's one of those things that once you've seen it, you'll never misdiagnose a case. It's just quite an interesting neurologic condition. So it's a dog with narcolepsy. I think this one genuinely does have narcolepsy because he actually does look as though he's asleep. It's often induced by excitement, which is why we're feeding him food, because when you give them food, often the excitement of the food is enough to make them go into their cataplectic and narcoleptic attack. So the cataplexy is where he's losing the muscle tone, losing the muscle tone and collapsing. And the narcolepsy is when he's actually sleeping. One of the reasons for showing this video, sorry, I'm drinking.
I hope everything is okay.
Yeah, sorry, I'm just going to have to drink something. One of the reasons for showing the video is because if you see the video, it's very obvious what's wrong with him. But if you have an owner describe to you, oh, my dog collapses sometimes at exercise, you could be led down completely the wrong pathway. So it's just important to think about whether, you know, how an owner might describe this to you. and what other considerations you might have if an owner said to you, my dog collapses. This one, it's a shame it's got the title on it again. It's a dog with generalized myasthenia gravis that's showing very typical clinical sign. So it looks stiff and it's getting increasingly stiff. It's taking short steps on all its legs and then it's becoming unwilling to walk. So I think this is very typical for a generalized myasthenia gravis case, but this condition, the way that it's presenting could be other conditions. It could be a generalized muscle disease, it could be a generalized nerve disease, it could be other disorders of the neuromuscular junction. And so, although the presentation there is pretty typical, and this dog does have myasthenia, it's not necessarily going to look as classic as this one. The good case dog with a son. He does have a mild gait disturbance. A friend of mine recorded this. They used says where we get to sort of what this wrong with it in terms of posture reactions. So just showing you, going through some of these reactions. So the patellar reaction, the patellar reflex is clearly intact. He's just doing some of the other reflexes here as well, which is probably a waste of time, but he's doing them anyway. So one of the other things that we would always tell our students to look at is to look at the tone in the legs and to assess the tone as well as looking at the reflexes. And so you you sometimes need to think about assessing that as well, because it's useful for evaluating for low motor neuron disease in particular, that you get reduced tone in low motor neuron diseases and increased tone sometimes in upper motor neuron diseases. So this one, there isn't much to see in it. I'll show you in the next video, and it tells you the diagnosis. This is a dog with mild generalized tetanus, and the thing that gives it away actually is the when you have a look at the dog's face. This is when it presented, and you can see the palpebral fissure. It's got the ruffled up skin between the ears, and the ears are sticking up in a slightly abnormal position. You might sort of ignore that if you don't know the animal all that well, but on occasion, I have even asked owners for photographs of their animal before they present it, because very mild tetanus can be difficult to diagnose sometimes. And so if you don't know what the dog's face normally looks like, you can sometimes miss it. But when the dog came back again a month later, you can see that the palpebral fissures are very wide. It's not got that furrowed brow. And you can see that there's a change in the dog's gait as well. And so before, when it was throwing its feet out quite wide, it was probably because it got increased tone in all its muscles. And so what it was doing was throwing its feet out wide because it couldn't flex its joints properly. So it's tending to throw the feet out wide.
Yes.
So it's just quite an interesting case where the danger is on focusing in too much on the neuroexam, and that if you look at the animal more generally, you get a better picture for what might be going on with it. So I think the reason that I said at the beginning is that I think that it's a bit of a non-question is because if you do a neuroexam on all these cases, you'll detect the animals with neurodeficits. So you do your exam, and if they've got neurodeficits, then it's got neurodisease. So the only time when that doesn't happen is if you've got episodic conditions. And so the episodic conditions that I've shown you that may be difficult to diagnose might be things like the aortic thrombosis, generalized neuropathy, generalized myopathy, that tend to show increasing weakness with more exercise. So the answer to that one is to ask the owners to provide you with a video. You know, most people have got cell phones. They can cell phone video and bring that in to show you, which is often extremely useful. I used to work in practices before we had cell phones, before we had people bringing videos, and it was much, much more difficult to diagnose some of these. The other thing to do is just to take the animal out and get it to walk, and get it to walk over quite a long distance perhaps. If the owners are telling you that the dog can't exercise properly, the answer might be to get it to exercise, because then you'll see these deficits. Like the animals with myasthenia, you'll detect them. All the other cases, you're probably going to detect neurodeficits. I think some of the most difficult ones that we deal with here, and I suspect that this might be some of the ones that you're asking me about the difficulty between ortho and neuro, yes, are the ones where they've got both. And so that is a real problem. And I agree, we have problems with that too. And I think that that is very difficult. One of the things I would say is that there are a lot of things that we see MRI that are abnormal in normal dogs as well. And the classic thing for that is the protrusion of a disc at the L7-S1 space. It's extremely common. It's extremely common in large breed dogs. Just pretty much all normal large breed dogs have a protrusion at this level by the time they get to be middle-aged. And most of the time it's asymptomatic. And I think you have to have quite a lot of other signs to be sure that that is symptomatic. Like you'd have to have compression on the transverse scan. You'd have to see nerve compression on the transverse scan, which you can't see here. You maybe have to have electrodiagnostic abnormalities, which is what we would use the electrodiagnostics for. If we can detect electrodiagnostic abnormalities, then we'd say, yeah, the dog's definitely got a neuro component to this, and that it likely is important. Or we might detect other neurodeficits like weakness in the hock, deficits in the anal reflex. I'm focusing here particularly on lumbosacral disease because it's probably the one that we have most trouble with. Then you'd have the X-ray as well. So this is a dog that we had in recently where we were wondering, was it lumbosacral or was it a hip dysplasia case? The dog came in for a hip replacement actually because it's got this degenerative joint disease in the hip. And the dog was lame on this leg. It also did have evidence of a lumbosacral disorder. It wasn't this dog's MRIs. But when we did EMG on it, it got decreased nerve conduction velocity in the back legs. Then we did the front legs, and it had decreased nerve conduction velocity in the front legs. And so actually the cause of the dog's exercise intolerance was probably that it got generalized neuropathy, that the owners complained that the dog couldn't exercise like it could do was probably because it got generalized neuropathy. And so even though it's got this lesion here, we still thought that we couldn't recommend doing a total hip replacement because the reason for the exercise intolerance was probably a neuropathy. And the reason for saying that is that it would be rare for a very bad, even a very bad hip arthritis to cause exercise intolerance. That animals with bad hip arthritis, yeah, sure, they're going to be lame. They're going to be lame when they first get up, especially. But as they exercise for longer, they're probably going to get, if anything, going to get better. Whereas this dog wasn't doing that. And so I think that quite a lot of the things where you still have a problem. So usually, if you've got a lame dog that comes in, like a dog that's lame in its front legs, and you find neurodeficits, it's probably because it's got neuro disease, and that the ortho disease probably isn't important. If it's got ortho disease and neuro disease, then it's got signs of both, like it's got spinal disease and orthopedic disease, they are much more difficult to differentiate. And I think the things that you might think about here are to do with duration of the clinical signs, like how do you fit that together with what you've seen on your scan or on your x-ray? So if you're seeing degenerative joint disease in a hip, and the owner says, my dog was normal until 3 weeks ago, it's unlikely to be the hip, actually, because the hip's going to have been like that for a long period of time. Admittedly, they can sometimes get worse acutely, but you'd sort of think maybe you should be looking for other disease, like maybe you're looking for its concurrent cruciate rupture. Because we very commonly, we see probably about 2 or 3 cruciate rupture cases a week here present to neurology. And that the reason that they present here is because of their lameness. And the vets think that it's neurological. But the dogs do sometimes have neurological signs. But the dog, actually, if it's got a fresh cruciate rupture, that probably is the cause. If it's got a chronic cruciate rupture that we can tell because it's got loads of fibrosis, it's got buttressing around the joint, we would ignore that and think neuro disease that's causing the problems for the animal. So it's often to do with the way that they've come on. The other part of it can be to do with the response to treatment. And so I'm thinking here of the brachial plexus lesions, that if they've had a treatment for arthritis that's appropriate, they should have responded, but an animal you've got neuro disease because if they've done previous steroid drugs and they've responded, that makes me think that it could still be either. And if it's responded very much better to steroids than it's responded to non-steroidals, that would make me think it's got neuro disease, because neuro disease on the whole tends to respond much better to steroids. And then, of course, we use the electrodiagnostics. So perhaps I'm telling you that go out and buy electrodiagnostic machines. But seriously, they're not very expensive nowadays. They're certainly a lot cheaper than a new X-ray machine. They're certainly cheaper than a MRI, and they're about the same price as an ECG. And I used to use an EMG machine in primary care practice, and I used to use it more often than I used the ECG because it was more often useful to me in making a diagnosis. Anyway, that's all I've got to say, and I've probably been going on too much anyway. So if anybody's got any questions, I'll be happy to answer them. And here's my email address if people want to get in touch with me.
Thank you so much, Professor Nicholas, for this interesting, very interesting, actually, even if the affection is written under the video, it's still very interesting to see this group of differential diagnosis. I'm very grateful for this interesting lecture, actually, and I see if one of our colleagues have questions. Can share something? Give us a second, please, to see if there is anyone who wants to take a question. someone, one of our colleagues, Dr. Nicholas, want to give a comment on slide 21. If you kindly.
Yeah. Do you know what the question is about? Oh, are they asking about this 2-engine gate?
Yeah, as a sign of Wobbler disease.
Yeah, I'll just share.
For the Great Dane dog?
Yeah, I'll share the screen again so you can see it. Can you see it?
He want to make sure, Professor, that this
You
gate
can't.
two-engine gate. This is called two-engine gate.
Two-engine gate. Yeah, it's a sign. Yeah, it's a sign of Wobbler disease.
Right. I just want to comment
Is that
about
the gate? That's the question.
Yeah. Can you see the video? Can you see the screen?
No, we cannot actually see the screen video, Professor.
Now I can see it.
Yes, now we can see it. Now we can see it.
Okay. So this dog, I don't think really does have a 2-engine gate. You're right that some animals do show what's known as the 2-engine gait, and usually that means that they're taking short steps on the front legs and longer steps on the back legs, and that's usually what people use to, you know, that's usually what people are describing by that. It's usually associated with lesions in the C6 to T2 region, rather than C1 to C5. This dog here, I think is showing. I think this dog is showing a C1 to C5 more typical gait. So it's got that thing where it floats, and people often talk about this thing about them floating when they've got the C1 to C5, and that's the more characteristic thing there. I don't think I may have a video somewhere else of a dog with a 2-engine gait, but it's usually associated with C6 to T2. You do have to be a little bit careful actually, because you can get it with lesions in the high thoracic area as well. So it's not completely diagnostic for wobblers.
Yes, Wobbler syndrome, Professor Nicholas, Wobbler syndrome. I know that it is common in Great Dane, and it is C1, C5 neurological affection. So we can consider this gait is little characteristic in Great Dane for this neurological affection. I mean, Wobbler syndrome, like wobbling gait of the hind limb.
Yeah, I to be honest, I would say that that most Great Danes present with C1 to C5 lesions. They usually show that. The more typical thing for other breeds is the C6 to T2. I'm just trying to find the video actually, because I've got a very good video of a 2-engine gait. And I'm just trying to find it for you so that I can show it, because I have got one. The problem is, I think it may be quite oh yeah, here we go. Here's one. Let's see. Oh yeah, this is a very good video. I'll just share this screen with you, okay? Because I've got the video. I'm just going to work out how I get the right thing up to share the screen again. Got it. Okay, right. I'm getting there. Okay, I'm going to show it. Okay.
Yes.
With it's a Bernese Mountain Dog.
Yeah, yeah, Burmese mound.
So that's a, did you see the video?
Yes, we can see the video. Nicholas Jeffrey, Professor.
Yeah. So this is a classic 2-engine gate. So that's got the very short steps on the front leg and long steps on the back leg. So that's a classic 2-engine gate. So I would associate that with C6 to T2 or possibly slightly further down in the thoracic area.
Mm-hmm. Yes.
Very occasionally you see animals with T3, L3 lesions doing something similar as well. But it typically is C6 to T2, yeah.
Yes. Can we take another question? Nicholas Jeffrey, Professor Nicholas Jeffrey? Can we take, yes, please. Our colleague asked about aortic embolism. If there is an appropriate test or appropriate method for diagnosis, like diagnostic test or diagnostic approach. Thank you so
Yeah,
much.
it depends on, so the first thing is just to always take the femoral pulse in dogs that use of having some sort of disorder, because most of these dogs you can't feel a femoral pulse, or if you can feel a femoral pulse, it's very. The other thing you can do is to measure the blood pressure in the pedal artery. So you measure the blood pressure in the pedal artery in the back leg and the front sternum. And so the other thing you can do that we would use, I personally wouldn't do it, but we have ultrasonographers that can use ultrasound on the femoral artery and also across the abdomen to look at the aorta itself. Mm-hmm. And I think all of those will work. I've got some MRI pictures of dogs with aortic thrombosis. The MRI, you probably don't actually need MRI because you should better diagnose it methods. But I mean, MRI will definitely confirm it for sure.
It means that femoral pulse and pedal arterial blood pressure and pedal vein or pedal artery blood pressure. This is could be quite considered as a diagnostic for aortic embolism, right? Nicholas Jeffrey?
Yeah. Usually you're going to better diagnose most of them just on that sort of very simple physical exam. Yeah.
Okay. في أسئلة تانية يا شباب? Excuse me, Nicholas Jeffrey. I would like to ask them in Arabic if there is any more questions. Okay, just. شباب في أسئلة تانية لو سمحتوا، لو في أسئلة ممكن نكتبها بالإنجلش أو بالعربي على الشات عشان لو مفيش أسئلة نقفل. تمام؟ Our colleague asked if the Great Dane has a Wobbler syndrome or not. Great Dane, black Great Dane.
He's got a high neck lesion, C5.
Yes. Okay. Thank you so much. Thank you so much. Okay. Thank you so much, Professor Nicholas Jeffrey. I think this is a very interesting day for us to meet such a huge personality on both scientific and personal aspects. I and my colleagues would like to say thank you so much, and we are very grateful for this interesting lecture. Actually, I talked to them much more about Nicholas Jeffrey and your publications and in veterinary neurology. We are impressed with this activity actually, and we are happy, so pleased to meet such experience, and we would like to say thank you so much for this interesting lecture.
Thank you. Yeah, well, thank you for inviting me. It's good
Thank you,
to
sir.
talk to people. Yeah.
Thank you so much. Thank you so much, Professor Nicholas. Thank you so much.
I'm just answering one of the questions.
Yes, I know. Yes.
Muted. Cutting the tunnels. Oh.
اوكي. في أسئلة تانية يا شباب؟ في أسئلة تانية؟ في أسئلة تانية دكاترة؟ اوكي. Thank you so much. Thank you so much, Professor Nicholas.
I'll leave the meeting. Thank you to everybody.
Oh, thank you so much. Thank you so much. Right. Thank you so much, Professor.